Never take anything for granted. Well, that is the moral of the story, which I'm going to share with you with this short video. So let's see this case. This is a routine cataract surgery. She's a 75-year-old lady who has this intermittent white cataract, and she's scheduled for the surgery, and the surgery is being done under topical anesthesia. The incisions are created, air bubble is put, followed by intracameral lignocaine. Now is the time to put in the dye. So I go in and put in the dye and come up, and again I'm irrigating with BSS to just clear off the dye. And something strange I'm seeing here. There is a patch of blue cornea extending from my 9 o'clock position to the 6 o'clock position. It's on the inferior and the temporal aspect. Well, this is extremely rare. This looks like the endothelium is stained. Obviously, that's not the case. Well, this can happen only when the dye has entered into the lamella of the cornea. So probably I'm expecting a Descemet's membrane separation. The cannula has gone in. The dye has been injected in the lamella and a lamellar separation of the Descemet's membrane, and the dye has gone in and stained that area. Of course, I don't have an intraoperative OCT to show it now itself, but this is what is going in my head. So we don't have the privilege of video recording replay in the OR, but I'm going to check that out later on. So that is my gut feeling now intraoperatively. That is what must have happened. Now with the assumption that this area has a lamellar Descemet's membrane detachment, I don't want it to increase. So I would want to pressurize the antechamber always to ensure that the Descemet membrane is sticking on to the stroma. So the next, all the steps of the surgery are going to be the same. The rhexis is done, time to perform the emulsification. So as the phaco probe is introduced, I can clearly see a part of the Descemet's membrane at the incision having folded upon on itself. It's almost looking that it is getting ready to rip off. So this entire zone is very vulnerable to get detached or torn. I need to be extra mindful of this situation at hand now. And whenever I'm going to use this side port, I need to be extra careful I don't tug or pull the Descements down further. So that is my primary focus on. The nucleus is divided into smaller fragments and then it's emulsified. Now, as is customary, I would just like to clean the posterior capsule by blowing it up with the BSS very gently. This helps to clean up the posterior capsule well. I want to pressurize the antechamber a lot before introducing my bimanual cannula. So whenever we have a soft eye and we enter through the incision, it's going to cause more stress and drag of the tissues at the incision, and it's going to increase the Descemet membrane detachment. So entering in an eye which is very firm and pressurized is going to minimize this complication. So pressurizing the eye with OVD before entering with the bimanual cannula does help. Now when I'm trying to do a bimanual I&A, I need to be extremely careful when I'm trying to introduce the cannula. I may rip off the Descemet's membrane in this region which is already hanging low. Now currently I believe that it's in the lamellar stage. Both the ends of the Descemet's membrane are still attached, but there is a central lamellar separation. So with that in mind, when I'm introducing the cannula, I want to ensure that it's directed posteriorly into the midvitreous, and then I'm going to enter it. Carefully, all the cortex is aspirated. Now is the time to put in the lens. Again, the cartridge, when it's introduced into this tight incision, I need to be extremely careful that I'm not going to push or tug at the already loose Descemet's membrane here. So again, when I'm introducing, the direction is much more posterior and my one eye is always focused on this area and looking at whether the membrane is getting ripped off. Thankfully, the implantation of the lens was smooth and the Descemet's membrane was not disturbed much. I'm going to introduce the bimanual cannula one last time to remove the OVD. Again, while introducing, I'm very mindful that the direction of the cannula is directed much more posteriorly. And once the OVD is out, time to close the wound. So I'm going to hydrate the other two wounds. I'm going to avoid hydrating this side port incision simply because I might extend or worsen the pre-existing lamellar descemet membrane detachment. So once the other 2 ports are hydrated, now is the time to put in the intracannular antibiotic. And before closing in, I would want to tamponade this area with a large air bubble. So I go in and inject a large air bubble which is filling almost limbus to limbus, and it looks to be staying there. And I'm hoping that it's going to provide enough tamponade for the early reattachment of the descemet membrane. At this point, I did have a thought of whether to use an expansile gas like SF6 or C3F8, but I thought this was a lamellar, and in only one quadrant I thought only I can get away with just the air bubble. So these are the first day post-op pictures. There is, as expected, corneal edema in this region. When we go ahead and do the cornea OCT, the lamellar descemet membrane detachment is very obvious. These are the third day post-op pictures, and the air bubble has shrunk in size, and we can see that the descemet membrane detachment is so well delineated. I'm just keeping my fingers crossed and praying so that it just spontaneously reattaches. If it doesn't reattach, then I have a plan of going in again and putting in an C3F8 gas bubble inside. So let's see how things turn out. So the message from this film is that never take anything for granted. I would have introduced the cannula through a side port for thousands of cases, but a momentary lapse in concentration can end up with an intraoperative surprise. Let us rewind and see what exactly happened here. So the first time the dye was put in, it was fine, and the patient just is moving a little bit of an eyeball. I just come out, and then I feel that I need to go in and put in a little bit more dye. When I'm going to reintroduce the cannula, this is the moment when the dye has been injected into the lamella of the cornea. This happened because the cannula has not gone totally into the antechamber. So when we inject at the wound, there is always a risk of lamellar separation of the descemet membrane and the fluid entering into that interface. So this is what has happened. So the first lesson which we teach all residents is never inject anything into the eye until we see the tip inside the antechamber. That is, it's well beyond the incision. Whether it is to the main incision or the side port incision, always try to inject only when we see very clearly that the tip of the cannula is way into the antechamber. This is a very basic concept which every eye surgeon would be knowing as they begin their training program. So a momentary lapse in concentration we could end up having such a surprise. I hope you found this helpful. Thank you for watching.